Support for this program comes from Genentech, the company that developed the treatment with a unique mode of action, Vabysmo, faricimab SVOA. With over 2 million doses worldwide and counting, find out more at vabysmo-hcp.com. That's Vabysmo, VABYSMO-HCP.com. RGX-314 could be a one-time gene therapy that addresses diabetic retinopathy. How did it perform in the Phase 2 Altitude study?
I'm Scott Kriswanis, and that was Greg Notestein, and this is New Retina Radio from Retina Today and Bryn Mawr Communications. Dr. Mark Barakat shares one-year safety and efficacy findings from the first 2 dosing levels of RGX-314 in patients with DR. What are the data, and what's coming next?
And Dr. Hani Salehi-Had joins the podcast to tell us about the findings in the Diamond study, a clinical trial assessing the safety and efficacy of OCS-01, an eye drop designed to treat DME. What did he and his study colleagues find? Keep it here to find out.
The last time we discussed RGX-314 on New Retina Radio meeting coverage was during the ASRS 2021 meeting in San Antonio. We heard from Dr. Mark Barakat about early efficacy data for the treatment of wet AMD. And now he's back, but this time we're exploring with Dr. Barakat the one-year results from the Phase 2 Altitude study, which explores RGX-314 in diabetic retinopathy treatment, not wet AMD. Dr. Barakat provided an update at this year's AAO annual meeting, and he's ready to fill us in. Dr. Barakat is the director of the Retinal Research Institute at Retina Consultants of Arizona, and he will soon be moving to Retina Macula Institute of Arizona. Dr. Barakat, welcome back.
Thanks so much for having me, Scott. It's my pleasure to be here.
We need to set the table for listeners who might not be familiar with RGX-314. Can you give us a primer on the therapy?
Oh, absolutely. So ABBV RGX-314, or 314 as we call it from here on out, is an AAV8 vector that encodes a monoclonal antibody anti-VEGF with the potential for long-lasting anti-VEGF therapy. And it can be administered in the clinical trials in more than one way. One is subretinally via surgery, but what we'll be talking about today is a one-time in-office suprachoroidal injection, so one-time therapy. And this is really ideal for the patients in a clinical setting.
Let's discuss the Phase 2 Altitude study, which explored 314 in patients with diabetic retinopathy. Who was enrolled? What did the study look like?
No, absolutely. So Altitude is a Phase 2 trial that has moderately severe NPDR, severe NPDR, and also mild PDR patients that do not have center-involving diabetic macular edema. So there's several doses and cohorts involved, and the results that we talked about are doses 1 and 2, so cohorts 1 through 3. These subjects received a single dosing suprachoroidally in the office at day 1, were followed for a year and treated with standard of care treatment as needed. The primary endpoint at 1 year was a 2-step or greater improvement in the DRSS score, but also with some secondary endpoints as well of interest. Going into details on this, the baseline characteristics were well balanced. And of course, we need to talk about safety as well.
Yeah, let's get to that safety. I'm curious what the results looked like at year 1 in the first 2 dose levels that you looked at in Altitude.
Absolutely. Of course, safety is paramount. And 314 was well tolerated. So that's the good news. At year 1, both dose levels 1 and 2 only had some SAEs. None were considered drug-related. There were no cases of chorioretinitis, vasculitis, occlusion, or hypotony. There were some cases of episcleritis, about 12% or so. These were mild to moderate, and these resolved with topical treatment. There are a few cases, about 6% or so, of intraocular inflammation, also mild, resolving with topical treatment as well. And this is in the absence of prophylactic steroid treatment.
That's right. So the first 2 dose levels did not have any prophylactic steroid treatment, right? What about the third dose?
The third dose will have prophylactic steroid treatments for cohorts 4 and 5. And so that is currently being recruited for right now.
Okay, let's get back to the altitude study. For the results that we do have, let's talk about efficacy. What did you and your team find at 1 year?
So essentially, at 1 year, the control group had worsening on average, which is to be expected. So about 37% or so of these patients had two-step or greater worsening of the DRSS, with only about 12% or so having a two-step improvement. At dose level 1, that narrative switched. So you had a 33% two-step improvers and only 16% two-step worsening. And at dose level 2, had none that had two-step worsening and about 21% or so improvement. If you were just to look at any improvements, so step 1 and onward, in control was 25%, in dose level 1 was 66%, and dose level 2 was 71%. So these were really robust numbers if you're looking for stability.
I'd like to hear about the efficacy results at 1 year. Dr. Barakat, can you tell me what you and your team found?
Absolutely. So in terms of efficacy, we're looking at DRSS scores, and you look at the observation control, and as you might imagine, about 40% or so of these subjects had two-step worsening or greater. Whereas if you look at the subjects that were treated with 314, dose level 1 is about 13%, dose level 2, it was less than 10%. So there seemed to be this robust decrease, or at least a signal for a robust decrease in terms of worsening of DRSS. If you look at the improvers, those that improved 2 lines or more, all comers for observation was 10% or so. And if you looked at 314 treated patients in dose level 1, it was about 13%. In dose level 2, it was 20%. So there's definitely a signal there.
I understand that you and your colleagues looked specifically at NPDR patients. How did they respond?
No, absolutely. And NPDR patients are of particular interest because we know from prior trials, those patients are the most likely to respond to anti-VEGF therapy. So when you look at the subcategory of DRSS 47 to 53, in comparison, in the control arm, you have about 37% or so that had two-step worsening and only 12% or so that had two-step improvement, to be expected. But if you look at level 1, dose level 1, 314, that narrative flips. Now you have 33% having two-step or greater improvement and only 16% having two-step worsening. And in dose level 2, you had 20%, 21% or so having two-step improvement, and no patients had two-step worsening. Another way of looking at that is any improvement, so 1 step or greater, was 25% of control, 66% in dose level 1, and about 71% in dose level 2. So really encouraging results.
I want to circle back to safety for a second. This is safety adjacent. Talk to me about vision threatening events in each arm of this study, both in control and then in the 2 treatment arms.
No, absolutely. So in any trial, it's not just about the primary endpoint, it's also about the secondary endpoint. The primary endpoint many times is something that we need to have that's FDA approvable, and that will be the two-step gainers or two-step losers. But as a clinician, we care about vision-threatening events such as progression to proliferative diabetic retinopathy, anterior segment neovascularization, diabetic macular edema. And so when looking at these NPDR patients in the control arm, the rate of that sort of complication was 37%, whereas in dose level 1, that decreased to 17%, and dose level 2, that decreased to 4%. So when looking at control to dose level 2, you have an 89% reduction, which is very robust. And that's really what we're looking for. This is the reason why we're looking for treatment such as this.
We still have not heard about dose level 3, which is cohorts 4 and 5. What can we expect next in altitude? I assume some of that data and maybe some more?
Right. So we all look forward to dose level 3. Frankly, if the profile of this drug is similar to what we see in dose level 2, that in and of itself will be robust. So if we can see a 90% reduction for a one-time in-office procedure, that'll be a wonderful thing.
Before we wrap up, I'm curious about the future or the potential future of a drug like this. Let's say the FDA were to approve a gene therapy for diabetic retinopathy in some form. In which patients would you put this drug? Who's the ideal patient? What do you see the real world utility being?
That's a great question, Scott. So it's really, what's the value proposition here? And going back a little bit, we know as a community that anti-VEGF treatment for diabetic retinopathy works. We have approved drugs for this. We know from our panorama trial, if you use this drug every 3 to 4 months, you can drastically decrease the rates of vision-threatening complications by 80% or so, and yet we don't do it. And you have to ask yourselves, why don't we treat these patients? At least according to real-world data, we certainly don't. And I think that's multifactorial. One of it is a treatment burden, the constant repeated need for injections. The other thing, these are working age patients. They can't always make it to the clinic on time. And frankly, they also have other complications. And so they may not be able to make it to the clinic on time. So a loss of follow-up is another component here. So here we introduce a potential therapy that's a one-time in-office injection with potential durable effect that may be able to achieve the same benefit in terms of reduction in vision-threatening events. So in that perspective, we know that the target population for this really would be the patients with non-proliferative diabetic retinopathy, those that are moderately severe or severe. Wouldn't certainly rule out those patients with mild PDR, but that will be on a case-by-case basis. So in other words, certainly not everybody that walks in your clinic with a little bit of diabetic retinopathy, but there's a healthy proportion of patients that could benefit from this greatly.
Well, we're looking forward to it. There'll be more data coming down the pike, as you referenced. Dr. Barakat, thanks for joining us on New Retina Radio meeting coverage.
Thank you, Scott, so much. It's been a pleasure as always.
Support for this program comes from Genentech, the company that developed the treatment with a unique mode of action, Vabysmo, faricimab SVOA. With over 2 million doses worldwide and counting, find out more at vabysmo-hcp.com. That's Vabysmo, VABYSMO-HCP.com.
The development of drops for the treatment of common retinal diseases could be the golden goose. If patients are empowered to self-administer drops that are safe and effective, then barriers to treatment would be significantly mitigated.
We might be inching closer to the possibility of drop-based therapy for DME. To learn more, we're joined by Dr. Hani Salehi-Had, a vitreoretinal surgeon at Retina Associates of Southern California in Huntington Beach. Dr. Salehi-Had, welcome to New Retina Radio.
It's a pleasure being here. Thank you for having me to discuss these exciting results.
The medication in question is OCS-01. Tell us about it.
Yes, OCS-01 is an eye drop that's aiming to be the first non-invasive eye drop-based therapy for diabetic macular edema. We can get into the science of how it's made, the way that we aim to penetrate the eye, if you wish, next.
Absolutely. Please tell us more.
So the formulation works by using cyclodextrin. Cyclodextrin is a cyclic oligosaccharide, which forms spontaneously into micro and nanoparticles. And these micro and nanoparticles then can incorporate any medication. And this allows for delivery of something that's hydrophobic, like dexamethasone, in a hydrophilic environment, like the tear film. So that's the mechanism by which OCS-01 is delivered to the eye and delivers dexamethasone to the posterior segment. And we think the route of penetration is through the sclera.
Your talk at AAO covered the DIAMOND study. It's a phase 2-3 study of OCS-01 in DME patients. Was this a pivotal study?
Yes, so this is the phase 2/3, stage 1 of the study. And this is aiming to come up with a dosing regimen for the second stage, which will be the larger stage phase 3 trial conducted in diabetic macular edema.
Tell us how you and your colleagues organized the study.
So the study is basically divided into 2 phases. The first phase is the induction phase. And in that phase, for the first 6 weeks, patient takes eye drops 6 times a day with the OCS-01. And the second phase is the maintenance phase, where patients start taking eye drops 3 times a day. And the aim is to see if we can continue to see gains, or at least maintain the initial gains that we see in the induction phase through the 12-week study. And it's a 12-week study with the primary endpoint being visual acuity at week 6.
And in terms of secondary endpoints, what were the researchers looking for?
The secondary endpoints are at week 12, basically looking at the same thing, visual acuity, also percentage of patients that gained a meaningful amount of vision, which is defined as 3 lines of vision, as well as central macular thickness. Now, of course, just like any study, we looked at ocular adverse events as well.
Why don't we move now to the efficacy endpoints? How did mean BCVA changes look at weeks 6 and 12?
So BCVA improved significantly by 7 plus letters at week 6. And this improvement was maintained and maybe slightly better at week 12. And this change was clinically significant compared to a 3-letter change rather for the control group.
You said you also looked at those who gained at least 3 lines from baseline. What did those numbers look like?
So 25% of patients in OCS-01 gained 3 lines of vision at week 6, and that percentage went up slightly to 27% at week 12, which was again also clinically significant.
And what did those numbers look like in the vehicle arm?
In the vehicle arm, at week 6, there was about 9% improvement of 3-letter gainers, and 7% for the 12 weeks.
So it sounds like functional vision was improved. Tell us about anatomic improvements.
So there was a significant drop in central macular thickness at week 2. So almost immediately after starting the drops, and that was the first time point that we looked at, week 2, there was a significant decrease in central macular thickness, and that decrease was maintained all the way across week 12.
And what about safety? Anything of note?
In terms of ocular adverse events and systemic adverse events, there was nothing unexpected. There was an expected and anticipated rise in intraocular pressure. And in terms of IOP increase, the IOP increased by 10, only in about 14% of patients. And there was only one patient that had an IOP of 35 one time. And so increases in IOP were according to expectation of what we thought based on prior studies with dexamethasone, and it was not a significant concern. The mean IOP also increased by only 2 to 3 compared to baseline.
To summarize, the study hit its pre-specified primary endpoint and its secondary endpoints. What's next?
So next is actually starting the larger stage 2 trial using the same drop regimen of 6 times a day in terms of induction, and then maintaining it at 3 times a day in a larger patient population and following them through longer to see if these increases continue to pile, so to speak, or they're going to be maintained.
Let's imagine that this drug is approved at some point in the future. I'm curious to hear how you think this treatment would fit into the overall landscape in retina.
So I think this is an amazing treatment to have, and maybe something that can be tried in the initial stages of your therapy. Our aim is to have a non-invasive treatment for DME. In terms of how aggressive that will be, it really will depend on the stage 2 results. This will be perfect and ideal for someone that's starting to have diabetic macular edema, and it's an eye drop that can be done non-invasively at home for them. And certainly if this is not getting them to where they need to be, you can switch them then into more invasive treatments of injections. However, I think having this treatment in our arsenal is really going to make a big difference for patients and patient outcome. You can imagine if a large number of patients respond to this treatment, and avoid needing injections, well, that would be a revolutionary change.
Yeah, for both patients and for clinics. So, Dr. Salehi-Had, thank you for joining us on New Retina Radio.
It's been a pleasure, guys, and hope to speak with you on future developments.
That's it for this edition of Late Breakers from the AAO annual meeting. We have a few more updates along the way, so make sure you are subscribed in your podcast feed.
And if you haven't subscribed, you know how to do it. Go into your podcast platform of choice and tap subscribe. It's free, it's easy, and we will have episodes automatically delivered to you.